I am Simone McConney. I'm the regional co-chair for DFA International in the North American and Caribbean region. And I'm joined by one of my fellow co-chairs, Mariam Boatros and Joel Aline, kind of our sidekick, but also from the Canadian Podiatric Medical Association. And thank you very, very much, Addie, for being here with us this evening, just to make sure that our technical aspect goes well. The theme this year, Global Action Against Preventable Amputations. And the theme we're looking at is the highs and lows of 2 feet and 10 toes and the value of limb salvage. And we know that diabetic foot is something that is sometimes taken for granted. And we see the rigors of that. So without further ado, I guess, first of all, I should remind you that this is a week of activities. It started on the 7th of November with the African region, and it will continue throughout this week. I'm just going to share my slides with you. And you can see the agenda for the week, and I'll bring this up again at the end. But right now, I'd like to start off with a message from the president of DFA International, Dr. Vijay Viswanathan.
As the president of the DFOOT International, I would like to welcome all of you to this DFOOT International DFOOT Awareness Week, which is being organized between November 7th and 14th. The main mission As the president of the DFOOT International, I would like to welcome all of you to this DFOOT International DFOOT Awareness Week, which is being organized between November 7th and 14th. The main mission of our organization is ending avoidable lower limb amputations due to diabetes globally. Our strong board and regional chairs are actively working towards achieving this mission and also seeking collaborations with various organizations in the world to achieve this mission. We wish you are there with us to listen and to also share your rich experience in diabetic foot with us during this week. Thank you very much for your attention.
During this week as well, we will be looking at various building teams and looking at the teams that we already have and moving forward with new teams. So this is our board for DFOOT, and then we have the regional chairs across the SACA region, the North American and Caribbean region, the European region, the MENA region, and they're all building capacity for us to save limbs and save lives. These are the true faces of the diabetic foot that we need to be thinking of as we move on tonight and we carry through with learning a little bit more about how we can work together, because it takes a team for us to save these limbs. This is our regional council, and we'll be hearing a lot more about them. And this is some of our regional teams. We now hand you over to Joel, who will introduce our first speakers for this evening.
Thank you, Simone. The speakers for Canada, Mariam Boatros, Dr. Ahmed Casey, and myself. I've worked with Mariam at the Wounds Canada in her role as CEO. Dr. Casey as well on limb preservation symposiums, and is an active member of the community and a board member as well for Wounds Canada. Miriam, I'm going to let you drive the slides for our panel.
Thank you, Joel. And I would like at this point to turn it over to Dr. Casey, who will lead us in this first part.
Very much, Miriam. Thank you, Joel. And thank you everyone for this this great invitation and opportunity. My name is Ahmed Casey. I'm a vascular surgeon and wound care physician at the University of Toronto in Canada, and also have been privileged to work with Miriam and Joel and our colleagues, several of whom are on this call tonight, to advance the limb preservation and amputation prevention agenda across the country. So tonight we'll be very briefly talking to you about some of the work that we've been doing and some of the challenges that we're facing, and hope to get your guidance and feedback and perhaps share some of our experiences with you as well. Next slide, please, Miriam. So where are we in Canada? We have recognized disparities in the management and prevention of diabetic foot complications. This has been well known for many years now, and perhaps further highlighted by the lack of a national diabetic foot care strategy. Our system in which we operate is a provincial priority, not a federal one. And so the way that healthcare is delivered in our country, the provinces deliver healthcare, and there's a federal umbrella under which we operate, but really it creates certain regional disparities as well. And we'll be talking about that shortly. So there are several social and demographic factors that are related to limb preservation and limb loss. Our country is no different than many others. You will recognize a lot of these trends in your own communities, perhaps to lesser or greater extents. And I'd like to thank Virginie Blanchette, who's also on this call tonight, for sharing some of these slides that we'll be using right now. So, diabetic foot complications are the leading cause of non-traumatic lower extremity amputations in our country. In fact, more than half of all cases in Canada are secondary to diabetic foot ulcers. It causes a lot of loss and sort of challenges, both financially and in terms of resources. And we struggle with a lot of non-healing wounds in our care systems, with a recurrence rate and a mortality rate that is quite similar to most westernized healthcare systems. So some of the social and demographic factors, well, we've got peripheral arterial disease that exists in about 4% of adults over 40. That's quite similar to most industrialized nations. However, there is a significant concurrence of lower extremity peripheral arterial disease in individuals who undergo lower extremity amputation in Ontario, which is Canada's largest province and where many of us reside. Now, we do have a national audience tonight with us, so there are variations across the country, but really you see this picture of both lower extremity amputations presenting as a complication of diabetic foot ulcers and also lower extremity diabetic foot. There's a huge mortality rate as well. So more than 80% of lower extremity amputations in Canada, this is more data, also concurrent PAD as well as major, diabetic foot complications. This is some national data that we generated a few years ago. And really the purpose of this slide is just to drive home the point that whatever study you look at, you're going to find similar trends. So where are we right now? Just going back to our initial slides, the majority of provinces have no formal uniform pathway for prevention or primary care or tertiary care or recurrence prevention. And this is a huge problem. And we're lucky to learn from a lot of the jurisdictions that are represented by DFUT who are able to come to the table and share some of their experiences about, how they perform and measure their activities in all of those. There are other issues. Access to foot and ankle surgery, podiatry, access to data gathering mechanisms are other challenges. There have been people who have done a lot of work in this. My friend Tom Weiss is on this call as well, and he's done a lot of work in this area trying to gather some of this data. So it brings home the message that I think that Diabetic Foot International has been very good at, which is driving home the message that you really got to have an interdisciplinary model to deliver this kind of care. This is not, you can't work in silos. And this is not news to anyone on this call. In fact, you're on this call because you believe in this. But how to gather data and demonstrate this to decision makers and policy makers is another story. And I think that's where Diabetic Foot International is so very helpful. So there are other issues that are perhaps unique in a certain way to our healthcare system. We have a very underprivileged Indigenous population in Canada's north that has some of the highest incidence rates of diabetes in the world. In some communities, they're only eclipsed by certain areas in the South Pacific. There are areas where my colleagues and I have traveled where the incidence of diabetes in the adult population is over 60%. So that, as you can imagine, it creates severe challenges for us, especially given the climate and some of the resource access issues that we have. And those challenges are multiplied by the lack of coordinated multidisciplinary care. Podiatry, as I mentioned, as well as foot care and orthotists are unfunded within our public healthcare system, which obviously is a huge problem and challenge, especially as these underprivileged communities are unable to afford many of those services. And we are seeing a similar trend in rising diabetes. I'm sorry, we're feeding our kids right now, and so I apologize for any noise. So we're seeing similar rising diabetes related amputations. Next slide, Mary. So in order to address some of that, we've formed some provincial coalitions to try and influence policy, and I'll give it over to you, Miriam, just to talk a bit about that.
Thank you, Alman. So as an organization, we certainly recognize that there are many challenges, and the way to overcome many of those challenges was to start forming coalitions to try and attempt and influence the policies and support decision makers and support building a community so that we can make the appropriate changes. We started off by forming a provincial coalition specifically in Ontario to influence the policy around universal offloading. And we came together as several not-for-profit organizations like Diabetes Canada, like NSWAC, like the Registered Nurses Association to work on it. And we were actually effective 4 years later. New growth and new changes were starting to happen as well across the country. In Alberta, they launched their provincial diabetic foot path, and that they were able to evaluate that pathway, and they were able to ensure that they had improved population health and 45% reduction in amputation rate. They had a return on investment for every dollar spent. They saved $7 because they reallocated that money into prevention, and they were able to demonstrate improved patient experience. So we started to see some improvements across the country. And Ahmed, can you comment on the work that is presently happening in Ontario?
Yes, of course. So we're we're currently working through one of the provincial agencies called Core Health Ontario to try and bring together a coalition of individuals who are interested in this topic to come up with guidelines and recommendations akin to what's going on in Alberta, so that we can learn from that jurisdiction that's been very, very successful. And the purpose of this is to try and come up with demonstration sites or areas where we can identify opportunities to test different models of delivery of care. Now, we are hampered by a couple of things in Ontario that Alberta got right. First of all, they have podiatrists. So a lot of the success that Miriam described earlier is due to the work of Dr. Karim Manji, who's a podiatrist and an extremely successful individual, both academically and clinically. And also Alberta's vision for a unified electronic medical record system that is able to capture a lot of these data points. So we don't have that in Ontario. We don't have that in Quebec. We don't have that in many other provinces across the country. So hopefully in the next few months, we'll be able to create these demonstration sites. We are mindful that each area has its own limitations and its own strengths. And so our goal in trying to test the different models of healthcare delivery is to be as fluid as possible and as accommodating of local situations.
And one of the other things, Ahmed, that we started to do is we have worked with you as the chair and as association, the coming together of Wounds Canada, the Vascular Society and Podiatry Canada, to build a limb preservation community. Can you speak to that?
Yes, absolutely. So when I returned to Canada from the US, where I trained in limb preservation, I was very lucky to meet Miriam and to work with her and Dr. Jim Hill and Joel and others who are visionaries in this field and who wanted to move the agenda forward. And one of the things that we recognized was the lack of a forum or an area where people can come to talk about these kinds of these kinds of issues. And so under the umbrella of Wounds Canada and in collaboration with the Canadian Podiatric Medical Association, as well as the Canadian Society for Vascular Surgery, we were able to form a limb or offer a limb preservation symposium where we brought together people from across the country to come and sort of chat and discuss some of these issues. I'm proud to say that we had representation from most jurisdictions, and we've had 3 of those so far, and they've been very well attended. The past 2 have been virtual for obvious reasons, and so we're trying to build on that success to try and really keep the momentum. We started a limb preservation journal, also under the auspices of Wounds Canada, to try and encourage people who may not otherwise be academically inclined to share their experiences and share their stories, and in a way help mentor them into developing their skills and communicating and connecting with other like-minded people. We have a very large country, and that presents certain challenges, as you can imagine. This has been very much thanks to the vision of Miriam and Barry Murray and others at Wounds Canada, who have been very supportive of this.
And at this point, I want to take it to Joel, who's going to talk to us, because Joel is the co-chair of our national task force, to talk to us about some of the things that we recognize as a community moving forward.
Thank you. And so one of the things that we do within the National Task Force is we bring together a number of professions in an interprofessional way to look at how we can move things along. And establishing a community, establishing a network of interested parties has been an important part of what we do. We're working to tackle healthcare inequalities. We're working to advocate for the reallocation of funds where we can. We don't believe that system needs more money. And as a matter of fact, we think we can save the system money in a number of ways. And we need to change the way that care is delivered. And we don't have the power to put these things into place, but we do have the power of influence, and that's what's been driving us. And it's important to us to build local networks, but also to build global networks. And that's one of the opportunities that DFOT International gives us and in our participation there as well. So building community advocates right down to the patient advocates is one of the things that we're doing. Now, as a national network, we're working towards the various pillars, supporting education. So the Limb Preservation Symposium and the publication, research, and we're currently working to bring a collaborative research culture and to bring a network of researchers together. We're also looking to see how we can reach out across the North American and Caribbean region to extend the arms of research and to reduce duplication. And then awareness, right? Leveraging data to improve awareness for the people that do make healthcare policy and healthcare regulations. In terms of finding our way forward, we have a number of challenges ahead of us. We continue to our efforts in the area of policy, research, education, awareness, and advocacy. We have worked hard on integrated diabetic foot pathways. You see Alberta has picked it up and run with it. Advocating for universal access, even within Canadian healthcare system, where we talk about universal healthcare. You can tell from the comments from Dr. Casey and myself, it really isn't universal healthcare if we don't have access to things on a consistent basis. Developing policies to enable every person with diabetes to undergo appropriate foot assessments, and our focus is on foot health. In a interprofessional approach, and through our publishing on a regular basis, annual basis, which we've already talked about. Now, we're looking to build global alignment, first within our region here in North America, but also in the global community, working with DFOT to further support research, policy, and sharing of educational resources, because we believe that together we can end preventable diabetic foot-related amputations. So that's what's driving us. So put the co-chair hat and say thank you to Dr. Casey and thank you to Miriam for this. And I'm going to quickly segue, and we'll come back to some questions in a few minutes, but I'll quickly segue into getting the US perspective. Now, Dr. David Armstrong and Dr. Lee Rogers are important to us in the North American context and important contributors. They couldn't be here with us because they're in surgery this afternoon, but they've come virtually to our virtual event, and they've provided us with the video. And Hattie, will you be queuing that up and playing it right now?
Hey there, David.
Well, hello there, Dr. Rogers.
Very good to see you. It's a Sunday. I know it's Diabetic Foot Awareness Week.
It is indeed. Hello from beautiful sunny Los Angeles, where it's always sunny. I understand now you are in beautiful Texas, yeah?
That's right. I'm here where you basically started your career in the diabetic.
That is absolutely right. In beautiful, beautiful San Antonio, Texas, and that's your great grandfather behind you, isn't it?
Yeah, well,
George Rogers Clark.
That's right. Yeah.
General
Yeah.
George Rogers Clark. How appropriate that a revolutionary general should ultimately give birth to a revolutionary doctor. How's that? In trying to make a revolution this time against amputations.
Well said. Well, I know we're here as part of an entire week of events that are going on with around the world, with our colleagues in various regions. And we're part of the North America, Caribbean region. And I think this day is dedicated to our region. This is going to be, we're pre-recording this because you and I are both going to be in the operating room on Tuesday, but we're just a couple of days early to get this out of the way. But I want to thank our colleagues from Canada and from the Caribbean for tolerating our absence, if only physically, but not mentally. And we'll be paying attention and wishing everybody well as we try to get this message across to everyone.
Well, here's to that, right? And here's to getting the message out. We're talking about different regions around the world, but this is unfortunately, as you know, a problem that doesn't really have any borders.
Right. That's right. So let's kick it off with some talk about what we're doing in America. So we'll focus on the U.S. That's our area, and there's a lot of things I think we do in the U.S. that are right and correct, but there's also many things we do that are wrong. We tend to focus on the correct things. We focus on these advanced technologies that we've been researching, and we talk about those around the world. But they're, in our own country, we have our own problems. And I think one of the biggest problems is this disparity that exists in our own country between the haves and the have-nots. And I'm talking about limbs. Those that have lost a limb tend to meet, a specific demographic or socioeconomic class. And that's swept under the rug in the past, really. But I think there's been a lot of attention lately to this, correct?
There's no question about it. This is unfortunately, like in many parts of the world, it is a zip code lottery. And in the United States, I think writ nationwide, there is about a 10-fold variation based on where you are, in what zip code, in what kind of metropolitan statistical area, and whether or not you're going to get an amputation. And in fact, that is just as true in around the United States as it is in individual areas. I'll give you an example. In my zip code, or I should say in my county, here in Los Angeles, where we have a 10 million person county that is amazingly rich and diverse. It's diverse in terms of ethnicity. It's diverse in terms of socioeconomic status. And there is a massive diversity in amputation. And it is, again, a 10-fold variation here. And I think you just saw that a little bit of that slide from Kaiser Health News. You also see this kind of tale of two counties in one county here, where you can see these data showing that massive disparity. So we have a lot of work that we can do. I'm excited to say that, the good news about this, Lee, is that individual clinicians can make a difference. And if you're in one of these counties, and if it's often that you're in a certain hospital and a woman or a man that takes a problem like this on as a clinician and wants to make a difference, often can, because we see sometimes massive disparities just between two hospitals, where we will see high to low amputation ratios inverted in hospitals that are almost next door to each other.
Right. Well, I think we're going to be sharing a lot of these data on Tuesday, and you and I will just share them back and forth and retweet them or post them on Facebook. I think
Sure.
Your Twitter is @DG Armstrong. Is that right?
It is @DG Armstrong.
And I'm @Lee Rogers DPM. But we'll work in concert with our other colleagues and with DFoot International to make sure that these data get out there. But yeah, you're right about the Kaiser article, which I thought was, first, it comes from a publication that is a well-respected, very non-biased group that's looking at data and making these judgments. But they called this a mega disparity when they looked at the amputation rate between the differences between those who are typically white and in wealthier areas, and those that are Black and Latino with diabetes. So
There you are.
I think it's something that hopefully the next year or in the coming couple of years, we'll be able to report on how we're helping to change this, because it's not unsolvable. I think the sunlight is probably the first thing that needs to come here.
Well, I'll tell you what, one great thing is that even in extremely high amputation area where there had been a mega disparity in Downey, California, which is part of Los Angeles County, we have Rancho Los Amigos, which is a national rehabilitation center, which actually is the place where Bill Wagner and Jackie Perry and Bestman and others used to work on the diabetic foot. And there, and setting up a interdisciplinary limb preservation program, our group led by Tanzim Khan, TK Khan, showed that we could dramatically change high-level amputation there in a relatively short period of time. We just looked, and we were just reported on that at the vascular annual meeting, where we looked at about 1,100 or so procedures done over the last 4 years, 2 before and 2 after implementing this sort of hot foot line, as we call it. And that's actually been really acknowledged now by our Department of Health Services here in Los Angeles County. And we think it's something that can be scalable worldwide.
Yeah, that's amazing. Speaking of the history, you talked about the history with Wagner and where you are now, but the history of where you came from, where I am now at UT and Texas Diabetes Institute specifically,
yeah,
is really shares a unique history with the rest of the world that I thought this was interesting. You and I had discussed it recently, but this is, of course, Paul Brand, who didn't really invent, but he popularized the total contact cast for the insensitive foot.
Yeah,
a hand surgeon turned podiatrist, maybe, I don't know.
Well, I think he came before orthopedics. He was actually his initial training was in just in surgery and in hand surgery specifically, and people with leprosy, growing up of missionary parents in South India, and being trained in the United Kingdom. And then he came out to the United States, specifically to Carville, Louisiana, to the Gillis Long Hands Disease Clinic in Louisiana, which of course is now closed for the most part. But he popularized so many of the ideas. I mean, I think he forgot a lot more than just about all of us know in this area in dealing with the insensitive foot. One of them was in looking at the total contact cast. He saw that if you spread force out over a large unit area, and you make the thing irremovable, that you could probably help people heal these predominantly neuropathic wounds. And that's been really pretty terrific. And it's made a big difference, and it's getting more and more popular. It's been a long road to try to popularize this kind of concept, but it's been wonderful to see how that tradition that he started from Milroy Paul in Sri Lanka to him in India and then in the United States, now becoming popular not only around the United States, but around the world. It's pretty great.
Yeah, but I think at TDI was where some of the initial studies happened.
Absolutely,
not only the some of the studies that looked at the pressure and related to the diabetic foot, but also temperature.
Yep,
which Paul Brand was looking at temperature too.
We basically copied a lot of what he did. When I was a resident in Detroit, I had done some work with some of my co-residents and attendings like Bill Todd and others, and we took that to San Antonio. And of course, they had already known about this and then began using it kind of at scale. And then we continued to look at this, and there were 3 separate federally sponsored randomized controlled trials, either in San Antonio or later in Tucson, that showed that you can give someone a thermometer, a very inexpensive thermometer. Now they're less than $10 US, and people can dose their activity by checking their skin temperature, just like they dose their insulin by checking their glucose. And that is a direct descendant of the thinking of Professor Brand. He used to say that a wound will heat up before it breaks down, and he was right.
Well, you'll be pleased to know that they still have the cast room. It's one of the we have 2 full-time cast technicians.
Awesome.
Total contact cast every day.
Oh man.
And they're amazing. I mean, they're so.
Do you know that I still have the blueprints from that place? It's on my laptop. I should have shared them with you. I helped to design that foot clinic, and it's so awesome to see it up and running continuously. It's heartening, really is.
Well, I also want to spend a few moments and talk about where in America where we've been leading, but this has really been a big tent type of organization that you've created. And that's ALPS, not ALPS as in the European.
Matterhorn.
Yeah, we're talking about, this is not something that divides a continent, but we're bringing continents together, both geologically and philosophically. And
well, nicely done. I think that's right. I think it has been, one of the hardest things to do actually is, even though it's easy to talk about on a Zoom like this, it's hard to do in real life, and that's to work together with one another in a consistent way. What we have found is, but just because something's hard doesn't mean it's not fun, and doesn't mean it can't and does not and won't make a difference. And what we have found is that when we bring what we call the toe and flow together, podiatric and vascular surgery specifically, but many other specialties in medicine and surgery and physical therapy and occupational therapy and nutritionists and others and dietitians and prosthetists and orthotists, so many others, but specifically the toe and flow idea. When we bring people together, good things sort of happen. And what we have, and there's tons of data now from our team, from others around the United States and around the world showing that. But what we have found is that we spend a lot of our time matchmaking, where people will just email us or text us and say, hey, I'm here in this part of the country, or I'm here over here, and I just want to try to find my vascular or my podiatric or my diabetes kind of soulmate, as it were. What ALPS is, what the American Limb Preservation Society is it's really like a dating app and a marriage counselor, both, for bringing together these clinicians. And that's its main reason for existence. And it has been spectacular. It's just so wonderful. It's just gotten started. And there is so much interest. We've just given out our very first ALPS Traveling Fellowship, and that's to colleagues now at the Mass General at Harvard. They're going to come out and visit centers now, a couple of our centers that are sort of already established interdisciplinary programs, and those travel grants are going to just keep on progressing over the years, and it's our hope that we start generating so many more of these interdisciplinary centers, not just at Harvard and Boston, not just at our place, not just in your place, but really around the world. And then by the way, I hope you can be a site for ALPS now for these traveling fellowships now that you're there. I'm telling you right now, so you could say it live that you're going to do it, because I know there'd be plenty of people that'll want to come. But now what'll happen is these women and men that train will be able to go back to their unit and help to make a difference there, kind of get their center almost up and running, and then they can be a site to mentor young women and men coming.
Well, a special thank you to Dr. Armstrong and Dr. Rogers. Even though they couldn't be here with us, they've gone the mile in terms of preparing this this video for us. Shout them out on Twitter. This is social media week. Shout them out on Twitter. Say, if you have questions, you have a couple of options. One thing you can do is you can put them in the Q&A here, and we'll pick them up and try and deal with them. And you can also push questions off to them. Before we move on, Simone, I was just gonna maybe take a couple of questions from the group, if anybody has questions that they want to come forward with.
Well, I kind of had a question. So seeing no one's put anything in the chat or raised their hand or anything. I breathe deeply, and I'm very honored that, we can come together as a group, and it's been a long time in the making. But I always have that hanging question over my head, which is, limb salvage is so expensive and limb preservation is so cheap. And we have, when you look at the facts, there's a lot of data. I mean, Lee and David are always talking about data, they do a lot of research. And, you know, Professor Casey, you were talking earlier about the importance of the research. But my biggest question is, why can't we just do it? Why do we have to have research in Canada, research in the Caribbean, research in everywhere? And why is it that, you know, we can't just, as David said, working and building teams is very uncomfortable. There was a point in time I got in a meeting and I said, we all have a skill. Let's take our hats off and let's basically deal with what's on the table. And I think that, you know, that's a mindset that we're not trained with. So I'll stop talking, but it'll be interesting to just, you know, what are some of those barriers, and you know, as a North American and Caribbean region, is it more research? Because we have a lot of research, it's not translational. So yeah, what do you think?
I can give a few thoughts on this, and in fact, I give an hour-long talk on this very topic, Simone. So why don't you call me later? You know, this is a very, very complex issue, and I see my friend Jim Hill is on the call as well. We've been trying to get podiatrists a greater scope of practice in Ontario for several decades now, and this is a concept that is so. I mean, it's so obvious to me that if you've got people who specialize in taking care of feet and preventing foot complications, you're going to get better outcomes. I mean, this is so obvious. And yet, you go to all these decision makers, and the first thing they ask is, well, what data do you have? You know, prove to me that your agenda is as relevant or more relevant than the 20 other agendas that I've just seen this week. So, you know, part of moving the dial forward is to speak the language that these people speak. You are living this reality. You are taking care of patients. You are helping individuals keep their legs. For a lot of policymakers, they're seeing spreadsheets, right? You are competing with a lot of other priorities. And so, you know, Miriam's extremely good at this, by the way, although she's too humble to admit it. She's able to speak that language and be able to formulate things in a way that policymakers are able to understand. And through her leadership, actually, we were able to get funding in Ontario for total contact casts, for certain offloading modalities that, you know, to you, Simone, might seem so obviously important that, you know, why are we even having this conversation? So I think that the question about research is really it really alludes to getting data and generating data. And in our context, you know, I'm sitting here in Toronto, my friend Virginie is in Quebec. She's got to do the same thing for her decision makers, right? And if we come to them with data from your jurisdiction or from Lee or from David, they're going to say, well, no. How do you know this works in Canada? I mean, you know, as if biology changes once you cross the border. Makes no sense to me. It's frustrating. You just got to internalize it, cope with it, and keep moving.
Any other questions that are out there? Now you can put questions in there's a Q&A box on the bottom. You can throw questions in there, and we'll pick up on them. But I'm going to keep the program moving, so I'm going to turn it over to you, Simone, because you've got quite an array of people coming from the Caribbean today.
Right, well, that's why this time I thought the perspective from the Caribbean would be a little bit along the lines of research. And instead of reflecting on what's happening in the Caribbean, because to be honest, it's not too dissimilar to Canada. We are working, we've kind of changed the tune a little bit, and we're looking at the research, the barriers and the challenges. And through the discussion of these papers that are from our young up and coming researchers, we see that we're building capacity, and we're hoping that with time, we get there. So our first presenter is Saeed Rashad Mohammed. He's a fifth-year student at the University of the West Indies, St. Augustine campus, Trinidad and Tobago National Scholarship winner. He has a passion for surgery and medical research, and he's especially interested in the myriad of complications of diabetes and has recently contributed to the development of a training program. This training program, hyperglycemia in pregnancy in Trinidad and Tobago, and it's designed for healthcare professionals. But tonight, he's going to be talking to us about microbial profile of diabetic foot infections at a private wound clinic in Trinidad. Now, this is an ongoing study, so we look forward to the final results. Saeed, hand it over to you.
Good night, everyone. Can you just confirm that you can see the graphical abstract, everyone? Yes? All right, so my name is Saeed Rashad Mohammed, and I'll be presenting the preliminary results of our study, the microbial profile of diabetic foot infections at a private vascular and wound clinic in Trinidad. And a bit of background information first, perhaps. Trinidad and Tobago has among the highest rates of type 2 diabetes mellitus worldwide, with unpublished data from the NAC study conducted in 2014 suggesting that approximately 32% of the population over 40 years of age fulfills the criteria for diagnosis of type 2 diabetes. Diabetic foot infection is the most frequent complication of type 2 diabetes in the Caribbean, and it's been estimated that the government of Trinidad and Tobago spends over $85 million on an annual basis on the treatment of patients hospitalized with diabetic foot infections. To put that in perspective, that's approximately 20% of the healthcare budget on an annual basis. A 2003 study indicated that the Caribbean governments collectively spend approximately $220 million on an annual basis on the treatment of patients with diabetic foot infections. As I'm sure you're all aware, it's probably only increased since that time because the rate of amputations across the Caribbean has doubled and tripled in the intervening 2 decades. Diabetic foot infections are the leading cause of amputations in the Caribbean. One study reported that 85% of patients undergoing amputation in Barbados between 1999 and 2009 were diabetic. A similar analysis of amputations in Trinidad from 2010 to 2016 found that 91% of patients were diabetic. The most common reason for amputation in Trinidad is sepsis after diabetic foot infection, with almost 80% of these amputations occurring due to the patient presenting more than 7 days after the notice of onset of symptoms, at which point sepsis had already developed. The tendency for persons in the Caribbean to delay seeking medical care, that is that late presentation after 7 days of noticing symptoms, in favor of self-care or home therapy or home remedies has been termed the Caribbean substitution culture. And that culture has been linked to a longer duration of hospitalization and a higher rate of major and minor lower extremity amputations. By contrast, a multidisciplinary approach to diabetic foot infection has elsewhere been associated with increased limb salvage and a lower rate of lower extremity amputations. One interesting study in Spain following on 15 years of a diabetic foot pathway and a diabetic foot specialist clinic noted that there was a major reduction in minor and major lower limb amputations after the introduction of the clinic and an infectious disease specialist with the management of these diabetic foot infections. As you're all aware, soft tissue infection and extensive gangrene are both indications for lower extremity amputations. And one review on the history of diabetic foot disease has opined that the greatest advance in the management of diabetic foot infections since the introduction of insulin in 1922 is in fact antibiotic therapy, because antibiotic therapy in diabetic foot infections lowers mortality. It allows for a greater rate of minor amputation as opposed to major amputations, and it has made primary closure with sutures a safer option. That's a bit of background information. The aim of this study, therefore, was to determine the bacterial pattern of diabetic foot infection at the first visit to our clinic and to identify suitable empiric antibiotic therapy or therapies. We retrospectively analyzed the microbial profile, that is the pathogen and the antibiotic sensitivity profile of all diabetic foot infections treated at our clinic between January 2014 and May 2020. This clinic used an automated system, the Vitec2 compact system for microbial identification and susceptibility testing. As indicated, our data collection and the analysis is still undergoing, so this is preliminary results. We expect to include perhaps 50 to 75, maybe even 100 final more ulcers in the final analysis. For the sake of brevity, I don't think I can go through the entire table, so I'll just discuss the results, the few salient points, and then I'd like to compare that trend to the existing literature. So I'll first compare it to the international trend, the international data, and then more specifically to a 2013 paper by Islam et al. And that paper and the comparison might explain the reasons for some of the research and why research must be an ongoing process across the country. To provide some context, that paper by Islam et al. Reported the microbial profile of 139 diabetic foot infections from 122 patients who presented at a single public tertiary care facility in Trinidad between July 2011 and June 2012. So with respect to the results of our study, we noted a preponderance of gram-negative aerobes, that is in 88% of the ulcers, and we noted a rather low rate of polymicrobial infections in less than 10% of the cases. We isolated only 13 gram-positive bacteria, that is less than 10%, 8 of which were Staphylococcus and only 1 of which was MRSA. The table displays the data for the most prevalent gram-negative aerobes and the 13 most tested antibiotics. As a brief note, we would have tested over 35 antibiotics over the course of the 6 years on the study. Each organism would have been tested against maybe 10 to 15 organisms. So this merely represents the most tested organisms over that 6-year period. The limited number of gram-positives meant that it was very difficult for us to draw any concrete conclusions regarding the appropriate therapy at this stage, other than the fact that beta-lactamase inhibitors were efficacious. I think they all reported over 90% efficacy over this time period. And institutional limitations meant that we couldn't really culture any aerobes. However, there is sufficient international evidence to suggest that these are present in cases of extensive gangrene, and therefore they should be accounted for when choosing the antibiotic regimen. So regarding the international trend, our clinic reports a relatively high rate of Pseudomonas infections in almost 50% of our cultures. Recent data suggested that Pseudomonas is far more common in tropical regions than those regions with a temperate climate. And similarly, the latest studies indicate that gram-negatives are far more common in monomicrobial infections and also in infections that are moderate to severe in nature. We identified a very low rate of polymicrobial infection, that is less than 10%. As a way of comparison, recent studies over the past 3 to 4 years have reported rates between 25 to 85% of polymicrobial infections. We are unfortunately a bit unsure of the underlying reason for this difference. We do have a few hypotheses, which I'd like to discuss a bit later on. So to compare with the local data from 2013, as I mentioned, this was done in a single tertiary care institution in South Trinidad. So the authors of that study isolated 221 organisms from 139 moderate to severe infections. They found 65% of these were gram-negative aerobes, 32% were gram-positive aerobes, and 3% were anaerobes. They reported polymicrobial infection in 57% of cases compared to our 10%, and they found multi-drug resistant organisms in 26% of cases. The initial data from our study suggests less than 12 to 14% rate of multi-drug resistant organisms, primarily E. coli and Pseudomonas. In that study, Staphylococcus followed by Klebsiella, Acinetobacter, Pseudomonas, Proteus, and Enterobacter were the most prevalent organisms in order of descent. And they found that ciprofloxacin and ceftazidime were suitable choice of appropriate empiric antibiotic therapy because they both had over 70% susceptibility testing over that time period. By contrast, in our clinic, ciprofloxacin had a very low sensitivity rate. I believe it's less than 40%, and ceftazidime, although it wasn't quite tested as frequently as perhaps it could have been, was less than 60% effective. So there was no real data, as I mentioned, to explain differences between one local study in 2013 in a clinic perhaps 80 kilometers from us and our study, which started after their study ended. That is, we began about 2 months later and ran for 6 years. We do have a few hypotheses, and we hope to someday delve further into this matter. Firstly, our first thought is that the socioeconomic class of the patient presenting at a public versus a private institution is likely to be quite different. That is, the person at the public institution is more likely to partake in the aforementioned Caribbean substitution culture, which, as I mentioned, has been linked to more severe infection, a longer duration of hospitalization, and also a more severe amputation. And secondly, many of the patients included in the study are repeat patients, by which I mean that they are presented with separate diabetic foot infections, each unique in nature, multiple times over the course of the study. We had about 112 organisms and infections. However, there were only 48 patients. And one 2017 study reporting on 1,018 diabetic foot infections in 482 patients would have found that the pathogens causing iterative diabetic foot infection episodes are often less antibiotic resistant than the previous pathogen, which could perhaps also explain why our trending data has not shown an increasing rate of antibiotic resistance. Perhaps, as I mentioned, much more research will need to be done into this matter. So regarding our choice of empiric treatment, we took into account the recent suggestion of the importance of antibiotic stewardship, which is recommended by both the Infectious Disease Society of America and the International Working Group on the Diabetic Foot, and with respect to the management of diabetic foot infections. To briefly summarize the main principles of antibiotic stewardship, first, only treat those diabetic foot presentations which are a clinical sign of infection, that is, a positive wound swab is not enough to indicate antibiotic therapy. Secondly, one should choose the antibiotic regimen with the narrowest spectrum. Thirdly, this therapy should be for as short a duration as possible. That is, until the infection is clinically resolved, not until the wound has completely healed. And fourth, the potential adverse effect of any plausible antibiotic must be considered, especially if the patient has any impairment such as renal disease, which of course is very common in these diabetic patients. Lastly, also, this does not necessarily pertain to antibiotic stewardship per se. I believe that especially in our region, the financial stress on the patient should be considered because, especially in our institution, they pay for that therapy. So keeping those principles in mind, we recommend piperacillin tazobactam as empiric antibiotic of choice. Now, as I mentioned, this applies to our clinic. I don't think it would apply to all the hospitals throughout the country because our results were quite different from that study by Islam et al. And until we can figure out what are the reasons causing those differences, I believe each clinic or each hospital will have to do their own research, perhaps not publish it, but they'll have to do their own research to figure out what works for them at their institution and which follows these above mentioned principles. So we did have a few other antibiotic therapies which would have at first glance seemed suitable, cefepime, gentamicin, and all the carbapenems. However, we believe that each of these are not ideal first-line therapy for a variety of reasons. Firstly, carbapenem should be reserved for multi-drug resistant organisms or for diabetic foot infections that are refractory to first-line therapy. Secondly, we felt rather that the adverse effect profile of gentamicin implied that it is not quite suitable for empiric therapy, especially in a diabetic patient where their kidney function has not yet been evaluated. And finally, also, although cefepime was quite suitable across the board for the infections, it does not prevent or protect against anaerobic coverage. Now, we could not really evaluate the anaerobic coverage. However, the international literature suggests that in terms of severe infections, and also in case of extensive tissue infection and gangrene, there's a relatively high risk of an anaerobic infection, and therefore coverage should be used. And piperacillin tazobactam provides excellent anaerobic coverage. So those are the reasons that we believe at our clinic in Trinidad that piperacillin tazobactam is suitable for empiric treatment. As a brief aside, the authors of the 2015 study would have found that ceftazidime, ciprofloxacin, gentamicin, imipenem, and amikacin were the most suitable choice of therapy. Fortunately, in keeping with their results, carbapenems have had 100% efficacy. However, they found a relatively high rate of MRSA and multi-drug resistant Pseudomonas and Klebsiella. By contrast, we found only one case of MRSA over our 6-year study period, and we identified relatively high rates of Pseudomonas and E. coli, but not of Klebsiella. I hope I've been able to provide some information regarding the unique challenges of diabetic foot infections at our single institution. And I'd like to thank all of you for your attention and also the organizers of this conference for giving me the opportunity to present this research. And I'd like to leave you all with one final quote, and this is from Alexander Fleming, the discoverer of penicillin. The thoughtless person playing with penicillin is responsible for the death of the man who succumbs to infection with a penicillin-resistant organism. I only hope that this evil can be averted. Thank you all.
Thank you, Seed. If there are any questions for him, please post them. And it was a very thorough and very interesting. And I know that one of the challenges, one of the reasons behind this was looking at how do we compare with our infections and management of our infections with the other universal studies with regards to the options and choices of antibiotics. So if we're talking about working together as a team and working together as a group and bringing it all together, we also have to see all the different perspectives. So thank you very much for that. Moving on, because I see There is one question. Yes, please. Dr. Casey, you wanted to
Oh,
have, you had a
okay,
question.
sorry. Yeah. Saeed, can I trouble you to share your screen again? How much time
Saeed.
do we have for questions, Simone?
You have like 1 minute. That's
Oh my
fine.
goodness. Oh my goodness.
ahead.
Okay.
Go
Well,
ahead. We have a-
this was really, really well done. Congratulations on putting this together. I think you're describing a 40% Pseudomonas resistance rate, which is quite alarming, to be honest. And that is, that is similar to some of the trends that we're observing globally. Certainly in our jurisdiction, it's very much gram positive heavy, less gram negative. And what do you think is the reason for that? Why do you have so much Pseudomonas, and why is so much of it resistant to Cipro?
So the international data, from what I've read so far, and I'm sure I've read less than you have, Doc, but the international data suggests that Pseudomonas is far more common in the tropical regions and also far more common in persons exposed to water on a frequent basis. Whereas in the temperate climates, they found a very high preponderance of gram-positive, that is the Staphylococcus and the Streptococcus.
Thanks. I know we don't have much.
Apologies. I'm putting on my camera. And with respect to the resistance to ciprofloxacin, I'm afraid I really can't speak with that. One hypothesis that we did have at our clinic is that it may be related to the self-prescribed treatment or pharmacist-prescribed treatment, because from just speaking to the patient, not necessarily data collected, but we found that many patients who present to our tertiary institutions have often gone to a primary care physician or to a pharmacist and obtain over-the-counter medication and antibiotics. So we suspect that this may be related to it, because in our country and in our hospitals, we tend to prescribe augmentin and ciprofloxacin very haphazardly, to be quite honest.
We had a breakout of Pseudomonas in our clinic a while ago, and then we tracked this down through a QI project and identified that some of our nursing colleagues were using unopened bottles that were left at the patient's bedsides in the community, and those would be left open for numerous visits. And once we ended that practice, our Pseudomonas rates went down. I mean, I don't know if this is relevant in your context, but it shows how we can learn from one another.
Absolutely.
Any other questions? Thank you so much for that. As you said, it was rather interesting. Okay, so our next speaker will be Juan Martin Rodriguez. Juan, are you there? Oh, there you are.
Yes. Okay.
Right. So, Juan is completed his residency training in the abdominal and general surgery at Fuenlabrada University Hospital in Madrid. He joins the staff of Curacao Medical Center as a young, enthusiastic surgeon with diverse international experience. Alongside wound care, Dr. Rodriguez Vitoria has a special interest in vascular and trauma surgery. Juan, your turn.
Hi, thank you for the invitation. Well, I'm going to talk about an update on COVID and limb amputation in Curacao. First of all, I'm going to give a general view of the situation on the island. Curacao has a population of 165,000 persons. Here, the prevalence of diabetes is around 16.4%. And what do the numbers tell us? Well, we have to compare with other parts of the world, of course. We know, according to the International Diabetes Federation, that the global prevalence of diabetes in the population between 20 and 79 years is around 9.3%. The EDF has divided the world in 7 different regions, and our region, that is North America and the Caribbean, has the highest rate of diabetes prevalence. that is around 13.3. In our region of North America and the Caribbean, Curacao is the 4th country with the highest prevalence of diabetes. That is 16.4, as I already mentioned. And we have one of the highest rates just after Martinique, Barbados, and Guadeloupe. So the relationship between amputation and diabetes is so strong that around 70 to 90% of the patients that have an amputation have diabetes. In Curacao, the average of amputation, of major amputation in the last 8 years is around 118. From this, 65% were below the knee and 35% were above the knee amputation. This graphic is not telling us much, only that at least the number of procedures has not increased in the last years. We have to combine these numbers with the population to be able to compare with other places. Here we can see that the major lower limb amputation rate per 100,000 population in Curacao has decreased from 82.4 to 66.6, with an average of 72 in the last 8 years. Also, if we see the COVID period from 2020 to 2021, we see that the continuity of the decreasing stays there. If we compare this rate with the studies, with this study that compared the rate of amputation from different places in Europe, North America, and Asia, we can see that Curacao is close to the worst rate, comparable and after the center of Navajo in the United States, where they have an important community of Native American with high prevalence of diabetes. Here we see that they have around 90, and in Curacao, we are close to 72 now. In a more recent study published this year of the rate of amputation in Trinidad and Tobago, that is closer to our situation, we can see that also the rate is far away from Curacao. So here is around 38, and the last rate in Curacao was 66, so still we are far away. The only thing that we can see here that the tendency here is increasing, and in Curacao was a little bit decreasing. It's interesting in this article that they mentioned that even that they have started with the vascular unit with also endovascular procedures, even that they start with that unit, they saw this increase in the amount of amputations. About the COVID situation in other places, we can see this study that was published in the Diabetes Care shows that in England, all the amputations done in the COVID period is slightly less than before that period. On the other hand, we have this study done in India that showed that in the COVID period was an incrementation of the amount of amputation. But this study was done only in one center and with a few amount of patients. So in conclusion, we can say that there has been no increase in the rate of major amputation in Curacao in the COVID period. Also, the rate of major amputation in Curacao is one of the highest if we compare to the rates registered in the literature.
Thank you very much, Juan. That's interesting. So with regards to your take-home message, sorry, I'm straight out the barriers here with question. What do you think contributed and remains to contribute to your reduced application rate? Because it's slowly coming down and it's not really changed. What do you think contributes to that?
Well, we haven't started already a program that is organized with multidisciplinary team, and we are looking for it. I think that these minor improvements can be just of personal reasons that are interesting in just a few amount of person, but not in a teamwork. That we are trying to organize that now. And also, we in Curacao, we haven't had any vascular surgeon. And in the last year, we just received a new vascular surgeon. So we hope that we have all the team already for it.
Okay. Thank you. Are there any other questions for Juan? Okay, it was a great update, one, because last year it was presented that, you know, everyone else was registering in COVID higher amputations and you were registering lower amputations. So it's very interesting to show that that trend did not actually change. Thank you very much.
Thank you.
Okay, so moving on in our agenda, our next speaker is from Barbados, Dr. Laura Lovell. Maybe Juan, you need to stop sharing your screen as well. So Dr. Lovell is a primary care doctor who has been working with the Multidisciplinary Center for Diabetes Management in Barbados since 2015. Her main research focus is on diabetic foot disease, but all aspects of diabetes and how it relates to overall health and well-being are her primary goal. She's also a volunteer at the Diabetes Association of Barbados, working with their type 1 diabetes support group as a clinical resource person. And I'm going to add here that Dr. Lovell has always been someone who was not that heavily focused on the diabetic foot. And now she is, because she not only likes the diabetic foot, but she likes vascular. And so welcome, Dr. Lovell, and thank you for joining our side of the world.
Thank you, Simone, and thank you again for the invitation to talk to you guys today about the study I did, which would reflect Barbados incidence, prevalence, and the potential risk factors for diabetic foot ulceration within a multidisciplinary center in Barbados. I did a study in connection with Alison Dunkley, Janet Jarvis, and David Webb and Claire Gillies in the UK. So a small background, Barbados has some of the highest global lower extremity amputations globally, with the odds of having a lower extremity amputation of 16.3. And there's a current dearth of primary care evidence about the diabetic foot, because most of these studies are based actually in inpatient diabetic ulceration. So there is a study out of Jamaica, which is the closest one done to this study, which dealt with a multidisciplinary center, but that was still done in the setting of a hospital. Mortality and morbidity in persons in Barbados living with type 2 diabetes and diabetes in general was actually 273.9 per 100,000 after major and 113.4 per 100,000 after minor amputation. And those were some of the highest documented globally that was documented in the early 2000s. There's not much recent research going on around these specific figures. So the particular aims of my study were to evaluate the incidence and prevalence rates for active diabetic foot ulceration in a population with diabetes living in Barbados. I also wanted to look at the exploration of risk factors for new and recurrent ulceration. The study design, it was a retrospective cross-sectional study with data extracted from the patient records of the electronic medical record at the center. We have a 6-month publicly funded program, so all study material, all patient records were extracted only from that public program, where everyone had a specific schedule of care, and eligible records for selected persons included persons with type 1 or 2 diabetes, and they must have been over 18. For the purposes of this study, an ulceration for diabetic foot ulceration was defined as a full thickness wound below the ankle. This was important because locally, unlike some other parts of the world, if you have an amputation, sometimes that itself can result in ulceration because it's left to heal by secondary intention. So those were exempt from the study. Trauma was also another exempt. Data were collected for current active ulceration, a history of previous ulceration within 1 year of the study period. And we then looked at the total population seen at the center over that period of time and divided as that. Statistical analysis was done using STATA, and I did logistic regression analysis to explore risk factors. So the results, the study population comprised of 225 individuals, the majority of which had type 2 diabetes of 96%. And the overwhelming majority were female, as has been seen in most of the studies, 70.7%, and 98.7% were Afro-Caribbean, which was also important because the only study which had a majority Afro-Caribbean was the Jamaican study. The mean age was 56.8 years. So the 1 year period prevalence was found to be 14.7%, which was higher than those figures found by Zhang et al. Of the global estimates. And the incidence of foot ulceration over the period was 4.4%. In table 1, I have there the general study characteristics of the participants. And we can see that eGFR, which is a measure of kidney function, as well as retinopathy, were some of the more significant characteristics associated with the risk of diabetic foot ulceration, albeit the numbers in the study population were quite low. So we didn't want to say, or we didn't say that it was very statistically significant, although we have the p-values, because again of the low population. So this study really needs to be repeated in a much larger population to say statistical significance. However, BMI, A1C, and ischemic heart disease did not show any correlation. In table 2, that's just a further explanation of the incidence and prevalence rates, where we have the annual prevalence of 10% in the foot ulceration group and the prevalence, the period prevalence of 33%. Now, when I did the univariate analysis, we found that of these, the total population was 225 participants, and the risk factors associated with diabetic foot ulceration included the retinopathy with an odds ratio of 3.85. We had the chronic kidney disease with an odds ratio of 9.86, aspirin use 3.33, and clopidogrel use, which was 3.13. The duration of diagnosis of diabetes and at age, we were using 1 year age intervals. Those did not have any increase. So in conclusion, both prevalence and incidence of diabetic foot ulceration observed were higher than seen in the global population. And future research through a larger prospective cohort rather than looking at retrospective records would actually allow the region to be more or provide more meaningful data to allow us to understand the risk factors, especially because the aim of doing a study like this is to identify the risk factors so you can do risk prediction models and therefore find your high risk groups and therefore offer your limited resources among the high risk groups. So if we can do that and do the models, I think that would be a useful benefit from this. Thank you. Any questions?
Thank you very much, Dr. Lovell. Any questions in the chat?
May I ask a question, please, Simone?
Sure.
I think that was a fantastic presentation, Dr. Lovell. Just wondering your thoughts on why hypertension was more strongly correlated in the univariate analysis than end-stage renal disease. I mean, conceptually, you would think that end-stage renal disease would have a much higher sort of impact on diabetic foot ulceration formation. At least that's what we've seen in other studies. Is there something particular about the community that you looked at?
Okay, excellent question. I think, again, this has to do with small numbers in the study because most of the non-recruited, but the patient records that we're looking at are persons who've had diabetes for a long period of time. So they may have also had the hypertension for that long period of time and not have developed the kidney diseases yet. But we have screened all of them for the kidney disease. So it may just be that those persons were not prone to the kidney disease, and we might have to look at a broader population or a larger population to actually see if they had an effect or not.
Simone, we're in an excellent position timing wise. We really have time for a few questions. If people have questions, it would be great to hear them or to see them in the chat.
Well, I may say that if there are no questions, if as well, Joel, maybe we can have a small discussion because I think that we saw the American side, Canadian side, and a glimpse of some of the things that are happening in the region. And what I offer today with these new studies are just a glimpse. So also in the absence of specific questions, we could also propose ways forward. You know, we sometimes become very tunnel visioned with what works. And has this helped to shed any light? And has this, you know, from the fact of being a hands-on person, you know, most of us here are hands-on with regards to our patients. You know, do you have any recommendations or suggestions and those coming through? And while you're thinking about what I said, there is a question or a suggestion that came up from Priscilla Provost, who was wondering whether the high prevalence of hypertension in the population with regards to the amputations, is that it? Could it be the high prevalence of hypertension in the population and the diabetic population? What specifically were you relating them?
That might have been a comment on something that was being said. I like your suggestion of a discussion. I'll keep an eye to see if Priscilla elaborates on her comment or question. But our panelists that are still here. Okay, here she goes. Yes, based on the study.
Okay. We do have a open question from Tom Wees, who said that even in a limb with CLI usually needs a precipitating event for the skin breakdown that is an ulcer. what preventive care is available even to the types of footwear that is common. I tried to imagine wearing a total contact cast on the beach and it was not a good image. It surely is not.
Floating on a piece of foam. Raft.
Actually, I think it will help them to sink, but yeah, get sand and everywhere. But Laura, do you want to answer that?
In terms of what is available?
Yeah, the preventative care. What preventive care is available even, can you see in the Q&A? So I'll read it again. Even a limb with CLI usually needs a precipitating event for the skin breakdown. That is an ulcer. What preventative care is available even to the types of footwear that is common?
Everyone comes in slippers. It's hot outside, people will tell you, oh, my feet don't agree well with enclosed shoes. So most persons wear slippers. And the truth is that there's no footwear fund. So even if you wanted to, in the public population where you have to self-fund it, if you told somebody, well, you have to go out and buy proper footwear that might help you not have an ulcer long term, persons will tell you, no, I'm not buying it. I don't have the money to buy it. So I think actually having more education of what the cost is like to have an ulcer probably may help. But yeah, common footwear is usually a very thin sole slipper.
And as a podiatrist here, I would comment as well to say that preventative footwear wise, again, there's a cost issue. So if we do have a patient with a buy-in that would love to be in preventative footwear, as I had mentioned, in some of our areas, total contact cast, although it is the gold standard, it's not always practical because it's actually expensive for its use. That's number one. So we tend to use a removable cast, and in some cases we may put a cable tie on there if we have a patient we can't trust. But there's a lot of education that goes into there, and also we will probably get patients to invest in their own care. So if we have the ability to have access, what we will do is import that boot or have that boot provided for them through a family member, because a lot of people have family that live, as you could say, overseas, which would be in Europe or the US or Canada, and they might be able to ship something in. Now with COVID, shipping is terrible. So offloading wise, we will probably go back to the basics of literally offloading walkers, wheelchairs, that kind of thing. From a preventative perspective, the only thing we have is education. And although we have access to custom orthotics, again, that's another very expensive route. So just trying to get them not to wear flip-flops and educate them on fitting, especially a neuropathic foot, to be fitted in an appropriate size shoe. I think the average person wears a shoe too tight. So I don't know if that helps to answer your question, but the costs are high.
There was a comment or a question in the chat that said the cost of diabetic shoes is also prohibitive for most diabetics in the Bahamas, and I think Laura said definitely here as well.
Yeah, Tom, I agree. We had started to address, there was a diabetic foot program that had started a couple of years ago, but like everything else, if certain individuals are shifted and policymakers are moved, those programs sometimes fail because the actual policies are not embedded within the system. So we were on the border and cusp of being able to put forward the importance of our government, because our government has a free healthcare system for all public, it's a public healthcare system. So that's where the cost is driven up. It's not an insurance-driven system. And the average individual doesn't have access to insurance or health insurance. So it's a little bit more difficult because it will have to be maybe creating some kind of fund that specifically addresses preventative footwear. And there are many studies, which is where I had started a little while ago when after Dr. Cassie's comments were the fact that, the policymakers want to see it here in this region. But we may get to a point where it's not always possible to do that one specific piece of research. And something like doing a research to prove the importance of footwear. As it is right now, importation into Barbados of products like footwear, you're looking at duties. So additional duties. So the cost of the footwear plus the additional duty of landing the footwear in Barbados, can run you up to 60% of the cost of the actual footwear itself. There are options of where you can get it duty free, but that is also a bit of a process to get everything duty free through that system. The ideal situation would be if someone qualifies under a specific criteria, they should have the ease of bringing that in themselves. So it's, as you say, it's not a simple solution for sure.
So I'm wondering if any of the other panelists have comments that they want to throw into the mix, since you invited them into the discussion here. I see we still have a few of the panelists in the room. Juan's here, Laura's here, Ahmed's here.
Joel, can I say something just as per Simone's comment? I think, that the notion that we have to do research, I agree with Simone that this can be a prohibitive barrier to individuals who may or may not have the bandwidth to embark on these kinds of endeavors. We're all busy. People have a lot to do. These are difficult patient encounters, and it's frankly sometimes draining work. It's very rewarding, but it can be draining. So I get it. We've started a limb preservation fellowship at the University of Toronto that's intended for vascular surgeons at present who want to spend a year learning the non-vascular surgery aspects of this. And one of the major components of our training is in quality improvement. And so they're required to complete a certificate in quality improvement, the purpose of which is to give them the tools to generate the kind of data that Simone is mentioning. So it's not really research per se, but it's giving them the ability to execute local projects that will give them the kind of information that policymakers will want to see, and also teach them how to set up interdisciplinary collaborations, because let's face it, at the end of the day, a lot of limb preservation and amputation prevention is actually quality improvement work. And I think that that's the part that we don't do well in our training programs.
I would agree, and I would agree.
Who else? I saw Saeed still here, Laura's here, Juan's still here. Anybody else want to come in with comments before we wrap up? Well, Simone, I think we should wrap up. We're about 20 seconds after 7:35, so we're right bang on the mark. Do you want to say anything before I do closing remarks?
Well, I just wanted to thank everyone for just being here. We've had a good participation. I hope it's whet everybody's appetite, and we're going to start busily getting ready for next year, because we're hoping that DFOT International will continue this as a program that helps to connect not only us in this region, because the regions themselves, we all tap into each other's programs. So I'm just sharing my screen there quickly again to remind you of, first of all, the culminating program will be on November the 14th, which is this Sunday, between 1 and 3 p.m. GMT. And it will be bringing all of this together and bring us closer together, hopefully. And then also for us to, you know, I just do want to thank Wounds Canada and CPMA and Addie for being up at this time to help us pull off this program. And thank you all participants as well for being here. And Joel, I want to hand over to you.
Yeah, well, I don't have too much to add to what you said in terms of closing remarks. I just wanted to thank the guests, because we have people from across the region, and I believe we have some international guests as well who are here. Thank you to everybody.